Thank you for viewing our presentation at the 2021 Annual Massachusetts General Hospital for Children Pediatric Research Day. My name is Kelly Berry, and I'm a medical student from Tufts University completing a research year with Dr. Elena Hawryluk. I am excited to present today a collection of local and published cases of pediatric melanomas to illustrate their heterogeneous clinical and molecular characteristics. The diagnosis and management of pediatric melanoma is challenging, in part due to the rarity of the tumor and heterogeneous phenotype. Recent integrated clinical pathologic and genomic analysis of pediatric melanoma has identified distinct subgroups with unique clinical behaviors. For example, kinase fusions for spitzoid melanoma, RAS mutations for congenital nevus-associated melanoma, and BRAF or TERT mutations in conventional adult-type melanoma. Rarer subtypes include germline BAP1-associated uveal melanoma and KIT mutations in acral melanoma. Because these subtypes are not well represented amongst adult disease, the distinct genetic and clinical relevance of pediatric melanoma and the implications for management in the pediatric population is under-recognized. Pediatric melanoma cases diagnosed and treated at Massachusetts General Hospital were identified retrospectively. Clinical images from distinct genomic subtypes were included. For subtypes without local clinical follow-up, a literature search was performed, and representative images and descriptions were included and cited. Clinical images and case descriptions are detailed in Figures 1 through 5 and associated figure legends. Figure 1 demonstrates a 1.6 centimeter spitzoid melanoma in a 3-year-old girl. Figure 2, a 1.6 centimeter malignant melanoma arising within a giant congenital melanocytic nevus of a 43-year-old female. The lesion harbored an NRAS variant. Figure 3 demonstrates a 5 by 10 millimeter acral melanoma in situ for a 9-year-old boy with a history of neuroblastoma. Figure 4 shows an approximately 9 millimeter superficial spreading melanoma with a positive BRAF mutation in a pediatric patient. Lastly, Figure 5 highlights a case published by Busam et al. In JAMA Dermatology of a melanocytic nevus with spitzoid component with loss of BAP1 expression in a 21-year-old patient with a germline BAP1 mutation. These patients are also at risk for ocular melanoma. In conclusion, pediatric melanomas present and behave differently than adult melanomas. Revised pediatric ABCDE criteria, where A stands for amelanotic, B for bump or bleeding, C for color uniformity, and D for de novo or any diameter, should be used to clinically evaluate for pediatric melanoma in conjunction with adult ABCDE criteria. Importantly, prognosis differs based on molecular characteristics. For instance, harboring of TERT promoter mutations portends a poorer prognosis in spitzoid melanoma. Conversely, congenital nevus-associated melanomas with NRAS mutations are highly aggressive with a uniformly poor prognosis. Our takeaway message is that integrated clinical pathologic and genomic classification of pediatric melanomas improve our diagnostic and prognostic capabilities and can meaningfully guide therapeutic management. Thank you so much for listening. Please scan the QR code if you would like to download or view our abstract.